So, I thought it's kind of fun to start by with a little mini lecture on some evolutionary adaptations for bipedalism. But don't make the same mistake that some previous PT students have made. They've assumed, because I'm really interested in this, that my lecture exam will be 95% about bipedalism. This is probably not a good study strategy. So these are prints in Africa, I think Tanzania. So what is that? Northwest Africa, or something like below Ethiopia, Eritrea, and it was early hominids called Australopithecus now that live, I don't know, like 2 to 3 million years ago. But so the interesting thing is, if you look at these tracks, they're not walking on all fours, they're walking on 2 limbs. So that was happening 2 to 3 million years ago. Of course, the interesting question that's still debated and is why primates left the trees in sub-Saharan Africa 2 to 3 million years ago, or maybe even a little more than that, to start wandering around on 2 limbs. And there's all kinds of theories out there. This is where I could, I think it's pretty interesting, but I risk going off on a 3-hour tangent, and then we don't get to the foot. But I am putting this here because the foot is also one of the main places in the human skeleton where we see major adaptations for bipedalism. If you look at a gorilla, just to give you a review, it's vertebral columns, mostly concave forward, like in a fetal human, and so it's center of gravity constantly being kind of pushed forward, and but we have sacral concave forward, lumbar convex, thoracic concave forward, cervical. Those curves that we talked about in the first lecture in this course keep our center of gravity between our legs. And by walking on 2 limbs, it frees up our upper limbs for tool use, for spear throwing. Some people think maybe it has to do with exposure to the sun. If you're a quadruped, there's more skin and surface area exposed to the sun, so it has problems with thermoregulation. Here it's just the top of our head exposed to the sun and the shoulders, so maybe there's a thermoregulation aspect to this. You can look over the savanna vegetation to see prey in the distance easier in this configuration than that configuration. So I don't know, people debate about it, why it happened. So one of the things we see is an alteration in the skull. So the large hole in the skull that you should have seen, because when we were talking about C1, C2 joint, atlantoaxial joint, and C1 skull joint, atlanto-occipital joint, I asked you to look at the bottom of the skull for the occipital condyles. They're right here. That is the part of the skull that is articulating with the C1 vertebra. But just between those occipital condyles is the largest hole in the skull, the foramen magnum. And in the human, the foramen magnum is directly above the spinal cord. So if you're standing, it's a vertical line, right? In a gorilla, it's completely different orientation, almost like 90 degrees to it. I mean, not quite. And this is a better configuration if you're walking around on all fours. This is a better configuration if you're walking on 2. So even in our skull, there is osteological evidence of this shift to bipedalism. Another major place we see alterations is in the pelvis. So in most other primates, the pelvic girdle is pretty tall and the sacrum is pretty narrow. In the human, the pelvic girdle got shorter and the sacrum got wider. This configuration helps with also keeping the center of gravity between the two legs when you walk. And another major feature is the orientation of the ilium. You remember there's 3 bones that fuse early in development: ilium, ischium, and pubis, to form the coxal bone. And so if you look at a chimpanzee or a gorilla, if you look here in particular, their ilial surfaces are kind of more posterior facing. So that means all their gluteal muscles are basically primarily extensors, like our glute max, but our ilial blades are more oriented towards the sides, and that allows glute med. I think that's pretty clear what I wrote. Don't you think? Yeah. Glute med and min. Yeah, I think I did a good job. That allows glute med and min to function as abductors, right? And keep the pelvis flat. Otherwise, when we would walk like we all had Trendelenburg gait, which is how a chimpanzee walks or a gorilla walks if they walk with 2 limbs, which they can do. Okay? Another adaptation you can see now down here at the feet, I'm going to talk about a few. Look at the configuration of the digit number 1 in the chimpanzee. It's abducted relative to the other digits. In other words, the lower limb feet are designed for grasping in a chimpanzee. They are not designed for walking on 2 limbs. In a human, all 5 digits are parallel. So there's been a reconfiguration in the lower limb osteology of the foot. That is a great configuration if you want to use the foot to press off the floor during the gait cycle to locomote. Look at Australopithecus, this early hominid from 2 to 3 million years ago that I started this mini lecture by showing you that picture of the footprints of. Its digits look like human digits. Its pelvis is starting to look like a human pelvis. See that? So, Australopithecus is considered a transitional form. I think that they were quite small. I think they were supposedly like 3 feet tall or 3 to 4 feet tall. But their skeletons are pretty similar to the modern hominid. I mean, look at the Q. Here's another difference. The Q angle in the chimpanzee almost non-existent. In the human, quite a large Q angle, which again is an adaptation to keep the center of gravity between the 2 limbs. If you don't have a Q angle, what happens is if you're a chimpanzee and you want to use a tool, because they'll use tools, they'll pick up sticks and use them as weapons, and I've seen them take a stick to dig it into a tree to get termites. Quite smart. But they'll flop from one side to the other. The center of gravity shifts left to right, left to right, left to right, because there is no Q angle. So in a human, quad, med, and min can function like abductors and keep our pelvis horizontal when we walk. The glute muscles in the other primates tend to be primarily extensor in function. Just talked about the Q angle. Moving on, I don't want to spend all year on this, like I said. So here you can see a, what is this? I don't know, is this a gorilla or a chimpanzee? Anyways, it's a gorilla. Its digit 1 is abducted from the other digits in its foot, but in the human, the big toe is parallel. So the human foot is not designed for grasping. More on that later. Okay, put it all together, a lot of adaptations. We can see evidence of this change towards bipedalism in the human skeleton, which is kind of cool, from the curvature of the vertebra to reconfiguration of the pelvis to the fact that the foramen magnum is at the bottom of the skull, not at the back, and to the shape of the foot. I've only talked about one of a few changes in the shape of the foot. Of course, the other one, which is also an adaptation for bipedal locomotion, is our foot has these beautiful arches, and we'll talk about that later. So these are some of the things that you can see, and I've said all of this. Moving on, and you don't need to memorize this. It's just kind of cool. I thought this was a cool study from the proceedings of the National Academy of Sciences. So can I just, little tangent, sorry. about my family. So my father's actually a part of this, the National Academy of Sciences. So he's always getting free gear, like free sweaters and t-shirts and stuff, and then they give it to me because I'm too cheap to buy clothes. So I got these sweaters that say PNAS, but like if you don't know what that acronym is, it just seems like I'm walking around with a penis shirt, a penis sweater. So my mom's always worried about me. You want to be wearing Dad's penis sweater? People aren't going to know what that is, Alan. Anyways, okay, sorry. So they decided to, this crew here, just think about like the energy efficiency of walking on 2 limbs versus 4. That's what this paper is basically about. The energetics of locomotion if you're a quadruped or a biped. And basically, without going this into too much, on the y-axis, this is an expression of the cost to move, like how much oxygen are you consuming per kilogram meter moved, or something like that. And you can see for a human, and basically if you're lower on the y-axis, you're expending less energy, basically. You can see as a human, significantly less energy expended than both a chimpanzee if it chooses to walk on 2 limbs, or if a chimpanzee chooses to walk on 4 limbs. Kind of cool little study. Moving on. Okay, I already spent too much time on that. So, think more about the bones of the foot. Explore that in the lab. And maybe I can. Yeah, I'll do it. I haven't done it before. I think I can. I think I can bring in some human feet. You're like, that's kind of scary, yeah. Where'd you get those? They're in my backyard. Sorry. No, sorry. Bad joke. No, looking for the same bone repository as intro anatomy. I'll bring over some human feet and we can look at the arches in the discussion part of Lab Wednesday, okay? We haven't done that before. So, we've talked about these metatarsals before, in particular the 5th and the 1st. The reason we talked about the 5th and the 1st is because fibularis brevis is attaching over here, and longus goes under the foot towards the 1st. Okay, so we talked about this before. But the other interesting thing about the metatarsals is they kind of jut out, as you can see here, and like particularly the 5th, and you'll look at that on these human feet that I bring into lab. You can see it's jutting out, so it's kind of easy to fracture. That's the point. It's easy to fracture, especially like in the context of excessive inversion. Right now, you're excessively inverting the sole of the foot. You're driving that 5th metatarsal into the ground potentially, right? Just a little radiograph of that beautiful Mortise joint of the ankle joint proper, and here you can see lateral malleolus, medial malleolus, blah blah blah. You start to see so we talked about some joints last week. Just a few more to think about. We could think about metatarsal joints, with the joint formed between some of the ankle bones, right? The ankle bones are the tarsal bones, and the metatarsal bones, which are these guys. There's the joint. Sometimes called Lisfranc's joint, and allows a little bit of gliding. Not a ton of movement here. Separate joint capsules for each of these. That's kind of interesting. And then there's actually, like if you look at 1 metatarsal, 2 metatarsal, 3 metatarsal, 4 metatarsal. That's interesting. Bill Gates seems to make an appearance at the beginning, but then as I'm going, he stops. Gets bored or something. I don't know. There are joints connecting to metatarsals, and so intermetatarsal joints, really little or to no movement. Plain synovial joints. The last ones are pretty important though, and these have counterparts in the hand. So And you'll understand these movements by the end of this lecture, hopefully. But let me demonstrate in the hand, because my hands aren't covered with shoes right now. So usually I do wear shoes on my hands, but today I'm not. So in the hand, the counterpart to the metatarsal phalangeal joint is the metacarpal phalangeal joint. So in the palm of your hand, these are the metacarpals. And then the little Roman soldiers, right? A line of Roman soldiers is a phalanx, right? That term comes from ancient Roman terminology, Latin. Soldiers lined up in groups and columns. Okay, so that's the joint, carpal, phalangeal joint, metacarpal, phalangeal joint. So at this joint, we can do two movements. Okay, we can do this high, and we can do this abduct, adduct, abduct, adduct, abduct, adduct, abduct, adduct. In the hand, it's relative to the third digit. In the foot, it's relative to the second. Abduct, adduct, flex the metacarpal phalangeal joints. We could add a piece to it. What's flexing, extending at the metacarpal phalangeal joints? Well, a lot of muscles cross that joint, so I couldn't tell you why. What are the muscles that abduct, adduct at those joints? Those are the interosseous muscles, the muscles between the phalangeal bones. So we'll think about that later. So abduction, adduction is due to interosseous muscles, same as in the hand. Then we get to the two joints in our phalanges. So we have a proximal interphalangeal joint and a distal interphalangeal joint. You know, digit one's different, but let's just take the middle finger. Proximal, middle, distal. So the joint between proximal and middle is proximal interphalangeal joint, the pip joint, and the joint between the distal phalanx and the middle phalanx is the distal interphalangeal joint, the dip joint. So those are interphalangeal joints, and they're both hinge joints. So they just do flexion and extension. And I was telling you, I think last week, like a good way to study is, maybe first learn it this way, and then ask yourself, okay, so like, what muscles are crossing the distal interphalangeal joint to cause flexion? Well, in the hand, flexor digitorum profundus, do you know what I mean? Okay, what's the nerve that innervates the muscle that crosses the distal interphalangeal joint? Well, that's median nerve, and of its branches actually, right? So you can do that. That's a good way to study. Do that for the lower limb. Okay, so hinge joints, interphalangeal joints. Okay. Okay. All these joints so far that I talked about are synovial on this slide. This is a little ligament associated with that metatarsal, tarsal metatarsal joint. So here's the tarsal metatarsal joint. Right, that's the line. And this is called the Lisfranc ligament. I think this was a French, surgeon or something. And it helps stabilize the midfoot, and it also plays a role in supporting the arches. So that's going to come up in a second. So we'll get back to that. Okay. And this ligament and this joint complex is sometimes injured. This is an example of such an injury where you got a posterior force coming down on a dorsiflexed foot, and you can cause damage here. I'll let your pathologists get more into that. Okay. Let me just think about this. Okay, so I think what I'm doing is I'm starting first to talk about kind of connective tissue and some ligaments. Then we'll talk about the arches of the foot, and then we'll get into muscles. So if you were to dissect for me, and we wanted to look at stuff in the plantar surface of the foot, it's actually a little tricky to do. You know, the skin down there is pretty thick, which is actually another adaptation for bipedal locomotion. The skin in the palm of the hand is not thick, people. Okay? And if you were to remove that skin, first thing you're going to see is this really cool connective tissue structure called the plantar aponeurosis. It's coming off the calcaneus, off the heel, and it's heading up and gives off these little slips to the toes. And it has a number of functions. One of them is to stabilize the longitudinal arches, which are in that configuration, right, along the longitudinal axis of the foot. It can also store energy, which we can use during the gait cycle. We'll talk about that later. So it's kind of a cool structure. And so it has some structural reinforcement aspects. And that's the first thing you see, okay? On the dorsal surface, we see some interesting connective tissue. So we see some bands of tissue that are wrapping around the tendons of the muscles of the anterior compartment of the leg. Remember, anterior compartment of the leg muscles, they're going to dorsiflex the ankle, extend the toes. They're crossing the ankle in front. So I'm talking about connective tissue crossing these three tendons in the front. Extensor retinaculum, they prevent bowstringing. Two sets, one up a little higher and one kind of Y-shaped, a little lower. That's the one you usually see in cadavers. Lots of examples are in cadavers. Okay, moving on. So that's the extensor retinaculate. There's actually flexor retinaculate. So recall that there are structures in the deep compartment of the posterior leg. So remember, posterior leg has two compartments, a superficial compartment consisting of two heads of gastroc, and underneath it, soleus and poor little plantaris. Just trying to tag along. All four of those things forming the calcaneal tendon. So that's like the superficial compartment of posterior leg, but if you remove that, now you're looking at the deep compartment of posterior leg, and that stuff has to get into the sole. It has to get into the plantar compartment. It's going to do it going down here through the tarsal tunnel. And just like any other set of tendons, we got to keep them nice and snug so they don't bowstring, and that's what the flexor retinaculum does. And why is it called the flexor retinaculum? Because the tendons of the three muscles in the posterior leg are going into the flexor compartment of the foot. Okay, it's on the sole. And why is the flexor compartment of the foot on the sole? Why is everything reversed in the foot and the hand? Because the limb buds early in development rotate in opposite directions. Remember that? Cool. Okay. So these are the things going through the tarsal tunnel. Into the sole of the foot. Tom, Dick, and very nervous Harry. That's the mnemonic for those things going into the plantar surface of the foot. But we're going to keep them snug in that tarsal tunnel by draping over the tunnel of flexor retinaculum. Okay? And just like in carpal tunnel syndrome in the hand, there's a just like carpal tunnel syndrome, there's a tarsal tunnel syndrome of the foot. And to kind of, predict what symptoms you might see in a patient with tarsal tunnel syndrome, you have to know what goes through this and what's going through there. Tibial nerve, like I just said, and the tendons of those deep posterior leg muscles. Tibial nerve, when it gets into the foot, is going to innervate the intrinsic muscles of the plantar surface of the foot. So you might have, and that's the flexor compartment, so you might have weak toe flexion. But we've also got some sensation on the sole of the foot. If you ever stepped on a piece of glass, you felt that. So we could have alterations in sensation on the plantar surface of the foot following tarsal tunnel syndrome. And what could cause this? Anything that's inflaming that region, causing less room for those structures to go through the tunnel, right? Okay. So it's like a counterpart to carpal tunnel syndrome. Guess what? Fibularis longus and brevis on the lateral side of the leg, their tendons are also covered by fibular retinaculum. So they don't bowstring. Let's remind ourselves where fibularis brevis attaches to the fifth metatarsal. There's fibularis brevis. There's its attachment. We just talked about how that fifth metatarsal is kind of poking out, and in the context of excessive inversion, you can get fractured. Longus is something cool, right? We've talked about this before. Here's tendon longus on the lateral side of the foot, and then it goes under the foot. That's why I'm dotting this, to the complete opposite side of the foot, to the big toe side of the foot. And it's going to attach on the big toe side of the foot, first metatarsal area. And in so doing, this is the exact orientation of the transverse arch of the foot. So fibularis longus tendon is going to hold up the transverse arch of the foot. How cool is that? So there is that tendon of fibularis longus going across the foot, way over here, towards the fifth metatarsal. See it? Cool. If you go down to that deepest layer of the sole of the foot, you'll see a little short plantar ligament. It's going right here. Short plantar ligament, also called calcaneocuboid, because we're going from the heel bone, the calcaneus bone, to the cuboid. Okay, so calcaneus to cuboid. Short plantar ligament. But we could drape another ligament actually on top of it. This is where our words become problematic. Actually, this ligament I'm about to describe is closer to the ground. Okay, you see what I'm saying? Short plantar ligament is closer to the head. Okay, it's higher up. There's a ligament underneath it is actually better, closer to the ground, called long plantar ligament. It also starts in calcaneus, but it goes all the way out, look at this, to the metatarsals. See that? And this one is perfectly situated to, if you think about it, help form a stabilizing function for the longitudinal arch of the foot, right? This is the axis for the longitudinal arch of the foot, like just perfect configuration for that. That's the long plantar ligament. Then the last one I want you to know, okay, is called the spring ligament. It's also running from calcaneus, and it's going to the navicular bone. So you could call it the calcaneonavicular ligament, or you could call it the spring ligament. This is important also for arch stabilization. Okay, and okay, so here's a beautiful actual cadaveric dissection where you can see the long plantar ligament going from calcaneus out to these are the metatarsals. And you can see it's going from calcaneus out to the base of the metatarsals. That's pretty cool. We can also in this dissection see the tendon of fibularis longus going across the foot way over to the opposite side. Fibularis longus in the process stabilizing the transverse arch of the foot, and we can see the spring ligament going from calcaneus to the navicular bone, and underneath, or really above the long plantar ligament, we can see a little bit of the short plantar ligament. So all those ligaments I just talked about in that cartoon, you can see on this beautiful cadaveric dissection. A little bit more about that
spring ligament, it's technically speaking coming off a little ledge on the calcaneus that I want you to know about. So like if this is the this is the tarsal tunnel side of the foot, right? This is the medial side of the foot. So stuff in the back of my leg, it's got to get to the plantar surface. It's not going to go to the lateral side. It's going to go to the medial side, around the medial malleolus through the tarsal tunnel. Okay, that's where we are. And if you were to look at the calcaneus, let's do it here. Let's just say calcaneus is boxed. It's not, but we can do that, right? And there's a ledge on this medial side, and the ledge is called sustentaculum tali. I have no idea if I spelled that right. Okay, and so this is cool because there's two things we want to know. You got to know this process, by the way, and I've been known to tag it on an exam. So the sustentaculum tali is a process of the calcaneus bone, but it's not a separate bone I'm talking about. Okay. So first thing is it's giving rise to a ligament called the spring ligament. Okay. The second thing is there's a muscle from posterior leg whose tendon comes down here through the tarsal tunnel and just wraps right around sustentaculum tali. So this functions like a pulley, flexor hallucis longus. How cool is that? So that muscle works more efficiently because it's wrapping around a pulley. It's kind of analogous to why we got a patella right here. Quadriceps is way more powerful because we stick a patella in there, right? Than not. And so two reasons we want to know sustentaculum tali, and relevant to here, that's what the spring ligament is attaching to on the calcaneus. Okay. It can cause, if you get rupture of this ligament, spring ligament, it can cause changes in gait. You can see this. Like I said 5 minutes ago, or 3 minutes ago, it's one of many stabilizers of arches of the foot. So you can end up with a flat foot if this ligament gets damaged, etc. Okay, so let's talk about arches, and let's do this first here. So a little bit is a tangent. I probably gave you, I found out the name, and then I forgot, sorry. For the ancient Japanese art of making buildings, and actually I learned something new. It's not just that they didn't use nails, they didn't use glue either. The joints are, and the joint that we talked about, this is like a preschool Japanese carpentry joint. Okay, the Mortise joint, that's easy. They have these like crazy interlocking joints. I don't know how they do it, but apparently it took years and years and years of apprenticeship. But anyway, so like you can tell I'm a little bit interested in architecture and stuff. So like if you go around the world, you'll just see in every culture the arch. It's just a common thing that humans make. Okay, you'll see it in churches, on bridges, because the thing is like, if you got, you could do that, but, it's probably easier or quicker to build something like that, and then stack some weight up here. But if you put too much weight up here, this actually isn't a very strong structure. This is stronger, okay? That's why humans invented the arch. And it's a great way to hold up a lot of the weight of the body or weight of a building. But over time, because of the forces of gravity, even though there's a really strong structure, because of the force of gravity, it's going to start to splay out this way, and the arch will collapse. So there's a few things we can do to prevent this. One thing is we can change the configuration of this top piece, make it look like that, make it more like a wedge, and that's called a keystone. And that actually adds stability and keeps the arch from collapsing. And then if you just had a square piece, By the way, we have bones in the foot that function like keystones. Another thing you could do is you could link these together. So like if you were making a bridge, you could add metallic staples, big staples to connect these so they don't splay apart. Guess what? We have those on the foot. They're called ligaments. Another thing you could do to prevent gravity from causing the sides of the arch over time to splay out is you could attach something from one bottom end of the arch to the other. And now that is going to resist that force, right? It's not going to go out. Guess what? We have that on the foot. We just talked about it. Plantar fascia is the obvious case, but also long plantar ligament. Okay, but you could do something else too. Like if you guys go into San Francisco next time and you go over the Bay Bridge, you'll see cables going up from the arches of the bridge. Those are suspensory cables. That keeps this, that resists the force of gravity, right? How cool is that? We have that too. Those are from tendons of muscles above the foot. You got muscles here, they send tendons down and they hold up the arch of the foot. We have all of that on the foot. By the way, this is called, so these are called staples. And in human terms, we could call that a ligament. Keystone is a keystone, that's a bone. And this is called a tie beam. If you want to tie one end of the arch to the other so they don't splay out, you tie beam them together. We have all of that in the foot. And it's all an adaptation for bipedal locomotion. So yeah.
Is it called the Miyadaiku method? Miyadaiku?
I don't know, but I saved an Instagram video about it. It's pretty cool. And I'll find out, but that isn't ringing a bell. But wouldn't surprise you if there's all different names for different kind of Japanese construction methods. Do you know what I mean? Yeah. They just beautiful like butterfly interconnecting the joints. It's crazy. So cool. No glue, no nails, just perfectly fitted joints. Okay, anyways, sorry, I digress. So, 3 arches, people. We got a medial longitudinal arch. This is the longest one. I'm sorry, the highest one. A lateral longitudinal arch. Often this is almost pressed down to the ground like when we're walking. And then a transverse arch running this way across the foot. There's 3 arches. And formed by various bones. I'm not going to verbalize all those bones. You can look at that, but okay. And you can see how, there's a keystone. Right? See it? A little keystone shape. Right? Talus or talus also functions as a keystone. So you put a keystone in an arch, and it actually helps stabilize the arch. And talus can function that way, and also some of these other accessory guys can too. We could add ligaments, little short ligaments connecting bone to bone. They can function like staples. We could add a tie beam, such as the plantar fascia, or some of those long tendons from the posterior compartment of the leg, like flexor hallucis longus, coming down here, right? Wrapping around that little syntacculum tali. And then we could have some tendons for muscles above the arches that function like suspensory cables, so like fibrillarius longus in a way functions as a suspensory cable to keep the transverse arch happy, okay? Isn't that cool? All these little, and then we got some passive things too. And so passive stabilizers are things like ligaments and stuff, but we got active things which are like muscles that are contracting and keeping the arches, high and happy. This is showing you some of the many things that help stabilize our longitudinal arches. Here is that sustentaculum tali in cartoon representation of the calcaneus. Okay? And you can see flexor hallucis longus wrapping around sustentaculum tali. So sustentaculum tali functions like a pulley, right? Okay. And you can see how plantar aponeurosis functions like a tie beam. In a way, so does the long plantar ligament. We've also got some suspensory cables coming down, like the tibialis muscles, fibularis muscles, things like that, okay? So fibularis longus, tibialis posterior, these are like suspensory cables, using an architectural analogy, keeping that transverse arch happy. And some of the cuneiforms forming like keystone shape, okay, keystone shape, okay. Now, you know, some people have really high arch, and you're going to be prone to supination, which is where a lot of your body weight is kind of centered more towards the lateral side of your foot. And you could, in contrast, have not much of an arch. Now you're more on the flat foot spectrum. And in this case, you're going to pronate more. And in that case, when we use this term pronation for the feet, we mean most of your body weight is more on the medial side of the foot. Okay? So high arch tends to lead to supination. Low arch tends to lead to pronation. Okay? And that kind of makes sense because, like, the tallest arch is the medial longitudinal arch. So if you're pronating, you're kind of you're impacting that medial longitudinal arch. Do you know what I mean? Okay. I think I read that the fastest human, who's the fastest human? Usain Bolt. Is flat-footed. Maybe, apparently, it did not affect his speed. Okay. I know there's great, you know, shoe fitting that can be done, and, you know, inserts that you can put in your foot to solve those issues. This is just kind of cool set of radiographs showing you a flat-footed individual on the right, and ways you could try and quantify this. I'm not holding you responsible for this, but like you could, you know, calculate the angle between calcaneus and talus, and compare that to the flat foot situation. That angle actually increases. Okay. And in contrast, you could calculate the angle between calcaneus and the floor, and that angle actually decreases in the flat-footed individual. But anyways, you know, you could try and quantify it. Okay. Give me a second. I'm doing all right. Wow. Cool. Might be able to do team viewer review too. Okay, so here's that plantar aponeurosis. Another thing, you know, like if I'm having my dissectors do this, I tell them to be aware of, once you remove that skin and you get to the plane of the aponeurosis, you gotta be careful on the edges not to damage the medial plantar nerve. And the lateral plantar nerve on the other side. Obviously, there's a lateral plantar artery and there's a medial plantar artery. You get the idea. So, like, if you're dissecting this out, you got to be careful that they're like right up next to the edge. Okay. So here we are, plantar fascia, and our plantar vessels on the side. At this point, I don't see any intrinsic muscles of the foot yet. All right. So this can function like a tie beam. It helps support the longitudinal arches, and it can actually store energy. I think that's one of the coolest things about this connective tissue. It also is protective in function. Like, think about prior to shoes, how this was a sort of protective function when we were walking around in our feet. And so when we toe off, right, at the end of the gait cycle, as right before toeing off, you can see what's happening to this plantar aponeurosis. It's starting to wrap around the heads of the metatarsals. Head, metatarsal, exaggerated. It's wrapping around that right before toe off. As it wraps around it, it stores energy, and then when we toe off, it releases energy. So it kind of functions almost like a spring. So it actually adds force to our, our gait cycle. Pretty cool, right? It's called the windlass mechanism. Winding it around the head of the metatarsal and then releasing that energy. It's kind of cool. On the downside, pretty common for folks to get plantar fasciitis. I think I was reading like 10% of like really hardcore runners will get this at some point in time. So that's a configuration that can cause plantar fasciitis. Sometimes there's no cause. Like my mother had it about 10 years ago, and she has no idea what caused it. But it's really painful. She reported a lot of pain. Repetitive trauma can cause it. Overuse, hence runners, right? Okay. We'll let your path people teach you more about that. Now, next layer, and just a little thing, because some of you, like the foot presenters, are starting to see this. Remember what's under this, right? Closer to the ground, coming off calcaneus, going to your feet, is plantar aponeurosis. So, to see these intrinsic muscles, you got to remove plantar aponeurosis. So often when you do that, what happens is, like if we cut it off back here, you're gonna, as you reflect plantar aponeurosis on this side, you're gonna have this muscle, flexion digitorum brevis. So you can see that in some of our body. On one side, you'll see what's left of plantar aponeurosis, on the other, flexion digitorum brevis. So we like to call this the first layer of muscles in the sole of the foot. There's 3 muscles, okay? There's a flexor, there's 2 abductors. We have an abductor going to the little toe and an abductor going to the big toe. We have dedicated abductors to both big and little toe. By the way, same thing in the hand. Okay, same thing in the hand, dedicated abductors. So, pretty easy to identify. This flexor digitorum brevis is the counterpart to the hand flexor digitorum superficialis. And like in the hand, and you can actually see it on this cartoon, and I want to make sure the presenter shows it is a really beautiful tendon mechanism. So let me draw this and show you what the problem is. The problem is in the hand and the foot. Okay. In the hand and the foot. If you want to get flexors out here's the phalanx. Distal, middle, proximal phalanx. Okay. And hand, same thing. Okay. So that flexor digitorum brevis in the foot stops here. Okay. So if this is what flexor digitorum brevis did, the problem would be that flexor digitorum longus is under this. So it would be, traveling under here, flexor digitorum longus, and it wouldn't be able to get past here. Right? It's like, right, it's stuck. So we get around that. This isn't how brevis attaches. Brevis does this. It bifurcates. And in bifurcating, it allows longus to go through the bifurcation and attach here to the distal phalanx of flexor digitorum longus in the hand, flexor digitorum profundus, in the foot, flexor digitorum superficialis, in the hand, flexor digitorum superficialis. Isn't that cool? So the tendon that stops short bifurcates and the long tendon goes through. It's a beautiful tendon apparatus. You see it in the foot, You'll see it in the hand. Presenters, make sure you show that. Okay. So that's what brevis is doing. It's going to the middle phalanges of 2 to 5, and it's bifurcating. You can see it here. It's bifurcating so that longus can go through the bifurcation and attach to the distal phalanges. What that says is that longus is the muscle that's flexing the dip joints. You know, I told you, like, how do we know what's flexing out here? What's flexing at the dip? Flexor digitorum longus in the foot, flexor digitorum brevis in the hand. Okay, those are the muscles that flex at dip. Make sense? Okay, that's the only one that flexes at dip because nothing else goes all the way out there. Brevis doesn't, so brevis can't flex at the dip joint. Okay, brevis is just going to flex at the proximal interphalangeal joint. Am I making sense? Okay. So this is the first layer of muscles. These are called intrinsic muscles, okay? That's the first time I've used that term. That means these muscles originate and insert on bones of the foot. None of them originate in the leg, okay? So it's extrinsic muscles of the foot that originate in the leg, or like if you're gastroc, you actually originate above the leg, right? Okay. Okay. Then we get to layer 2. And this is a really cool layer. So now let's just tie back to some of the things we've seen before. You see these things coming in over here. That's the tarsal tunnel. So this is where all that stuff going through the tarsal tunnel now starts to appear in the sole. And remember the mnemonic: Tom, Dick, and very nervous Harry. So Dick, which stands for flexor digitorum longus, is coming in like this and crossing the sole kind of obliquely, and then giving off tendons to digits 2, 3, 4, and 5. That makes sense? Okay. Harry. It's not a K, sorry. Tom, Dick, and Harry. Oh, sorry, that is an A. That's an artery. There's Harry. And that stands for flexor lucis longus. Here it is. Let's do it with a different color. It's exiting the tarsal tunnel, and it's going to the big toe. See it? It's going to the big toe. Going to the big toe. Notice the configuration of longus. Let's do this too. So here's calcaneus. Metatarsals, phalanges, okay, whatever. Okay, so we got flexor digitorum longus coming in like this and giving off tendons to 5, 4, 3, and 2, right? It's not going to 1 because there's a dedicated flexor to 1, right? Okay, but it's coming in like at that oblique angle. It's not really biomechanically efficient, so, right, because this is the long axis of the foot. This is the long axis of the foot. And this is the orientation of flexor digitorum longus of the foot. That's not good. Like if you want to flex, you can have the most powerful flexor if you're coming in parallel to this axis. You're coming in like that. No, that's not good. So we're going to solve the problem by adding a muscle in the leg running from calcaneus to this tendon. Okay. And that little dude is going to pull this tendon that way, so that the tendon, I mean, we think, this is all speculation, but the idea is like, this muscle, when it contracts, right, when it shortens, pulls the tendon of flexor digitorum longus close to the long axis of the foot, and in doing so, theoretically, flexor digitorum longus now acts more efficiently. Do you know what I'm saying? And that muscle's name is quadratus plantae. The square-shaped muscle of the plantar surface of the foot, right? Yeah. Right. Know what I mean? All right, let's stop there.